Dear students and friends, the next topic in my class series in OBGYN is vaccinations in pregnancy. You would agree that the corona pandemic has made us realize the importance of vaccines. I would be speaking on various vaccines in reference to pregnancy. So, I shall discuss the various aspects of vaccination in pregnancy. One of the greatest triumphs of immunology is the development of vaccines against certain infectious agents. Vaccination is the most successful and cost effective public health intervention, and it has led to eradication of conditions like smallpox and control of others like polio and whooping cough. Maternal vaccination protects both the mother and fetus from morbidity and at times mortality too. They provide infant passive protection against some preventable infections which are acquired independently after birth. Ideally, all these vaccines should be given prior to conception. There are some which are indicated in pregnancy, and there are some situations in which even contraindicated vaccinations with special precautions can be used in pregnancy. Now, let us understand the basics. Whenever the human body is infected by an antigen, there are two types of defense mechanisms and two different types of immunities. First is innate immunity, which is present right from birth. So it is older, less specialized, less powerful, but it is the first line of defense. It has poor specificity. Antigen may be non specific, response occurs within minutes, there's no memory, and the components of this type of immunity include epithelial barriers, phagocytes, neutrophils, monocytes, and macrophages. On the other hand, the other type of immunity is acquired or adaptive immunity, which is evolved later. It is more specialized, more powerful, has high specificity. It is antigen specific, slow response, which occurs in days. However, it has memory, and the components include lymphocytes, T and B cells, and their products, that is, antibodies and cytokines. It is this type of immunity which is used in vaccination. The definition: vaccine is a biological preparation that improves immunity to disease, and the process of stimulating a protective adaptive immune response against microbes by exposure to non pathogenic forms or components of microbes is known as vaccination. As I had said earlier, they work by inducing active or acquired immunity by providing immunological memory and generating antibodies against the pathogen. Now, about pregnancy, immunogenicity, and placental transfer, which may occur in pregnancy. Healthy pregnant women can mount a similar amount of immune response to vaccines, same as healthy non pregnant women. The antibodies which are generated are of different types. The transplacental passage of these antibodies depend on the maternal concentration, the antibody type. IgG type is the one which is useful. Then the subtype IgG1 and the gestational age. Fetal IgG concentration is much lesser than maternal concentration in the first half of pregnancy. Then this concentration increases to 50% at 28 to 32 weeks. Fetal concentration of IgG equals maternal levels by 36 weeks. And at times, the fetal concentration may exceed maternal levels at term in certain situations. Therefore, maternal IgG levels reach their peak about 4 weeks after immunization. And this is the reason why we want to give these vaccines approximately at early third trimester or 28 weeks, so that by 32 weeks a sufficient level of immunoglobulin has reached the fetus. The gestational age at maternal immunization is thus important, especially so when passive neonatal immunity is a goal. The ideal timing of vaccination is early third trimester to achieve maximum maternal antibody levels and maximum antibody transfer before delivery. If you look at the types of vaccines, they're mainly of three types: live vaccines, killed vaccines, and some are purified macromolecules. Live vaccines, they are inactivated microbes which have been treated to abolish their infectivity and pathogenicity but still retain their antigenic potential. Now, with these live vaccines, there's a possibility that this antigen may get incorporated in the host genome and again become virulent. And this is the reason why live vaccines can infect the fetus and they are usually not given in pregnancy. When we talk about killed vaccines, they are inactivated, killed, and they are inferior to live vaccines as replication of a living microbe confronts the host with a larger and more sustained dose of antigen. So a larger amount of live vaccine is required. Preparations are often injected and immune response does not take place at the site of natural infection. The third variety, the purified macromolecules. There are some conditions in which toxoids are responsible for the response. So inactivated toxins like diphtheria toxoid and tetanus toxoid are a type of vaccines. The second type in this is conjugated vaccines. They are basically carbohydrate vaccines and they need to be conjugated to a carrier protein to increase their immunogenicity. So Hemophilus influenzae, Neisseria meningitis, Streptococcus pneumoniae are conjugated vaccines. Sometimes only a subunit or a particle of antigen may be used in a vaccine. For example, the Dane particle from HBsAg vaccine. So these are known as subunit vaccines. Again, to emphasize the differences between live and killed vaccines, live vaccines generally require only a single booster. They are less stable. They activate both humoral and cell-mediated immunity. They may revert to virulent form. Only a small dose is required. They are given by a natural route and they are more potent. The killed vaccines require multiple boosters. They help in mediating humoral immunity. They do not revert to virulent form, can be given in large doses, and require an unnatural route, and they are less potent. If we classify the vaccines into three varieties, those vaccines which are used in pregnancy, it would be something similar to a traffic light signal. The red ones are the ones which are contraindicated, yellow ones which may be used in certain specific situations, and the green ones which are indicated. The contraindicated ones are BCG, measles, mumps, rubella, varicella, smallpox or vaccinia, and HPV. The ones which are indicated are inactivated influenza, pertussis, inactivated polio, tetanus toxoid, and diphtheria toxoid. Some vaccines may be used in certain situations when the benefit outweighs the risk. They include hepatitis A and B vaccine, meningococcal vaccine, pneumococcal vaccine, typhoid, rabies, and yellow fever vaccines. It is said prevention is better than cure. So we must think of various ways in which we can minimize the risk of infection exposure, especially so in pregnant women. They could be avoiding travel to high-risk areas, assuring that household members are immunized according to the standard immunization schedules, because these members also can infect the pregnant woman. Then, of course, maintaining good hygiene practices like hand washing, consuming clean water, cooking food adequately. Ideally, vaccines, some of which are live, should be given before conception. So, the concept of preconception immunization. Measles, mumps, and rubella infections cause adverse pregnancy outcomes, and if they occur in pregnancy, lead to an increased morbidity. Therefore, ensuring immunity against measles, mumps, and rubella, and even varicella, that is chickenpox, is important because these vaccinations are contraindicated in pregnancy. Before administering a live vaccine to a woman of childbearing age, it is a reasonable practice to identify whether the woman is pregnant or could become pregnant in the next 4 weeks. And for this, counseling is very important. Before giving a vaccine, the woman must be counseled about the risk to the fetus if she becomes pregnant within an interval of 4 weeks. However, routine pregnancy testing is not advised, but by a detailed history and through a checklist, we can confirm whether the patient is likely to be pregnant or not. If a vaccine is given, they must avoid pregnancy for 28 days. Manufacturers recommend avoiding pregnancy for 3 months following varicella vaccination. However, adverse outcomes in women who become pregnant soon after receiving these vaccines have not been established, and therefore, as a rule, termination is not advised but could be an individualized approach considering the pros and cons of that particular vaccine. MMR vaccine. Documenting immunity to rubella must be a routine component of preconceptional care because we know that rubella causes many fetal congenital malformations. The MMR vaccine is a live attenuated vaccine, is given to pregnant women who are not pregnant and there is no evidence of immunity to rubella. Evidence of immunity in women of childbearing age include documentation that the woman has received a dose of MMR vaccination, at least one dose containing live rubella vaccine, or a lab evidence of immunity, that immunoglobulins are present, or a lab confirmation of disease. The test determining rubella immunity is the IgG titer. IgM titer may be done only if there is a suspicion of recent or acute infection. Now, once rubella immunity has been documented by any of these, a repeat rubella serology is unnecessary in subsequent pregnancies. Measles vaccine is also given along with rubella vaccine. Again, measles, the condition becomes more morbid if it occurs in pregnancy, and therefore vaccination is essential. The varicella vaccine. Varicella zoster infection in pregnancy causes severe maternal complications, the congenital varicella syndrome, neonatal varicella zoster infection even. Non-pregnant women who do not have an evidence of immunity to varicella and who do not plan to become pregnant within the next month are ideal candidates for immunization. Two doses are to be given 4 to 8 weeks apart. ACOG and RCOG guidelines recommend to avoid pregnancy for at least 1 month after receiving the live varicella vaccine. Now let us talk about the routine prenatal immunizations which are essential. The first thing when we talk of immunization in pregnancy which comes to our mind is tetanus. So why protection against tetanus is important? Neonatal tetanus is rare in countries where universal immunization of children and adults with tetanus toxoid is a routine. The estimated vaccine effectiveness is nearly 90%. But in the developing countries, it is one of the leading causes of neonatal death, and it could occur due to unclean cord cutting and unclean care practices, unhygienic deliveries, and lack of maternal tetanus immunization. It is a preventable disease and can be very easily eliminated if tetanus toxoid is given to all pregnant women who have not been vaccinated or who have been inadequately vaccinated. And this helps in passively immunizing the fetus or and neonate as well. In addition to that, in order to eradicate tetanus, promotion of aseptic obstetric practices and postnatal umbilical cord care is essential. Now, Tdap vaccine, which includes tetanus, diphtheria, and pertussis, is routinely recommended in pregnancy. Pregnant women who had not been previously fully vaccinated against tetanus and diphtheria should also receive the tetanus diphtheria series. So, if these women have not received the 3 doses, then an additional dose of TD is to be given. Pregnant women who received 3 full doses of TD vaccine should receive a single dose of Tdap, ideally during the early part of third trimester, 27 weeks till 36 weeks of gestational age. Tdap is indicated in each pregnancy, even if the woman has a previous history of pertussis infection or vaccination, even if the consecutive pregnancy is occurring within an interval of 12 months. Women for whom 10 years has elapsed since the last TD booster, this Tdap dose in pregnancy serves as a booster for vaccination against tetanus and diphtheria as well. Now, if Tdap is not available or it cannot be given, a TD booster during pregnancy is recommended if more than 10 years have elapsed since the previous TD booster, or if it is essential for wound management. Booster protection for wound management is advised when the last booster was more than 5 years ago, or if a wound is not clean and minor. Tdap, however, if required, can be given earlier than 27 to 36 weeks and at any stage of pregnancy if a woman lives in an area with pertussis epidemic or requires a tetanus booster for wound management. Now, in these cases, if it is given early in pregnancy, it should not be repeated later in pregnancy. If Tdap is not administered during pregnancy, it should be immediately given postpartum to women who have not previously been vaccinated. This can provide protection to the infant indirectly, or if breastfeeding, 2 weeks post vaccination, it can provide protection. Vaccination of household contact, that's family members and childcare providers who are expected to have close contact with a newborn infant who is less than 12 months, is also essential. Inactivated polio vaccine is offered along with Tdap in some countries like UK at 28 to 32 weeks. The rationale behind the use of pertussis vaccine. The prevalence of pertussis is increasing, and it has been seen that immunity after vaccination or even after having the disease wanes over time. Adults who develop pertussis can transmit the disease to susceptible infants in the household, which is a concern because infants under 3 months of age are at the highest risk of morbidity and mortality from this disease. Various observational studies suggest a decreased risk of infant pertussis with maternal vaccination during pregnancy. Vaccination too early or too late may result in suboptimal protection. Now, the inactivated influenza vaccine. All women pregnant during the influenza season should receive it as soon as it becomes available and before the onset of influenza activity in the community, regardless of their stage of pregnancy. Vaccination after the onset of influenza activity may be still beneficial as long as the influenza viruses are still circulating. It is given as an intramuscular injection into the deltoid. Influenza is particularly morbid in pregnant and postpartum women and increases the risk of serious medical and pregnancy complications and at times requires hospitalization. Vaccination, on the other hand, reduces the risk of these complications and in addition to that, it also provides passive protection to the neonate. Inactivated influenza vaccines are safe for pregnancy, postpartum, and breastfeeding women. There are multiple studies which have evaluated its safety in pregnancy, and in addition to that, some vaccines which were used in the pandemic of H1N1 influenza virus, they have not demonstrated any increased risk of either maternal complications or adverse fetal outcomes. So it is comparatively safe. Now, about various immunizations which can be used in special circumstances. The pre-exposure prophylaxis. Some pregnant women are at a high risk because of comorbidities, their occupation, their habits, their area of residence, or have an exposure risk. Women who meet these vaccine recommendations should be immunized if a vaccine is available and is not known to have any harmful effect in pregnancy, and especially if the infection could result in significant harm to the mother or the baby. So the benefit versus risk is to be evaluated, then only the vaccine is to be given. In general, non-live vaccines are not more dangerous to the pregnant woman or her fetus than disease they are designed to prevent, although each vaccine should be considered individual. The pneumococcal vaccine. It is recommended for adults who have conditions that increase the risk of invasive pneumococcal disease. Ideally, it should be given prior to conception, but there are some indications in which it can be used in pregnancy, and if needed, it is to be given in the second and third trimester. There is no information on safety in the first trimester. The various indications include immunocompetent persons but having congenital heart disease, diabetes, chronic lung disease, alcoholism, or chronic liver disease. Then absence of spleen, either functional or anatomic, especially in women who have sickle cell disease or hemoglobinopathies. In immunocompromised individuals who have HIV, chronic renal failure, nephrotic syndrome, etc. So these are the indications for pneumococcal vaccination in pregnancy. Meningococcal vaccine, just as like pneumococcal vaccine, if it has not been given, it is to be given. In the same way, meningococcal vaccine, if it has not been given previously, it needs to be given in pregnancy. The usual advice is to avoid vaccination unless the mother is at high risk of disease. There is no evidence that either vaccine, the conjugated or the quadrivalent, is unsafe. So it is safe in pregnancy, but in special circumstances, like women who have functional or anatomical asplenia with immunosuppression, those who have complement deficiency, who have to travel to high risk endemic areas, who have contact with infected individuals, and who are university students less than 25 years of age. It has been found to be safe in breastfeeding. There are two types of vaccines which are available. The third vaccine is the Hemophilus influenza vaccine. It is an inactivated vaccine recommended in adults who have not received the childhood hep series and are at a risk for invasive hepatitis influenza type B disease due to certain chronic conditions like sickle cell disease, leukemia, HIV, or they've had splenectomy. So all these three vaccines, pneumococcal, meningococcal, and Hemophilus influenza vaccines, these are given to women who have immunodeficiency and these various conditions. All three need to be given. Hepatitis B is a recombinant vaccine that poses no known harm. The indications are pregnant women who are completing an immunization series which had begun prior to conception, now it has to be continued, or an unvaccinated, uninfected pregnant woman who is HBsAg negative but is at a high risk for acquiring hepatitis B infection, or the woman has certain high risk characteristics. The conventional recombinant vaccines are of two types, Recombivax HP and Engerix-B. Similarly, hepatitis A vaccination is indicated in certain conditions, planned international travel, injection or non-injection substance use, occupational risk of infection, close contact with a person who is an international adoptee or who is experiencing homelessness, so is at a risk for acquiring a HIV infection. If there is a concern for a severe outcome from HIV infection, like the personal history of chronic liver disease or HIV, if susceptible women are exposed to HIV during pregnancy, HIV vaccination and passive immunization with immunoglobulin are essential. Yellow fever is a mosquito-borne viral hemorrhagic fever that occurs in tropical regions of South America and sub-Saharan Africa, and it has a very high case fatality rate. Pregnant women ideally should avoid travel to these endemic areas. But if travel is unavoidable, vaccine may be considered. Polio is a systemic viral infection which has varied manifestations ranging from asymptomatic disease to paralysis, and it has almost been eradicated from various regions of the world. But transmission continues in certain countries like Pakistan, Afghanistan, Nigeria, Somalia, etc. Pregnant women should avoid travel if possible to these areas, and if travel is not avoidable and they've not been immunized previously, they can be immunized with inactivated polio vaccine. This is the one which is only recommended in pregnancy. Typhoid. Typhoid fever is a systemic febrile illness, mainly occurs due to consumption of contaminated food or water in the regions of Asia, Africa, and Latin America. Typhoid vaccination is partially protective and is recommended for persons traveling to the typhoid affected areas. Pregnant women should avoid traveling to such areas, and they can be immunized with inactivated vaccine if unavoidable. A live attenuated vaccine is also available for oral use, but the inactivated vaccine is the one which can be ideally given in pregnancy. Other travel vaccines include inactivated Japanese encephalitis vaccine given to pregnant women who are at a risk of disease exposure. Rabies vaccine is an inactivated vaccine, can be given as a pre-exposure prophylaxis during pregnancy if risk of exposure is substantial. It can be given with or without rabies immunoglobulin. Now, certain conditions, if there's a substantial exposure to an infection like smallpox and anthrax, these vaccines can be given, but only after adequate consultation with experts. The most important thing, immunizations which should be avoided during pregnancy. MMR vaccine is not to be given. Similarly, HPV. Worldwide, there's a use of bivalent, quadrivalent, or the recently launched nonavalent vaccine. Administration of any HPV vaccine during pregnancy is not recommended because of limited information about its safety. If pregnant women, after initiating the vaccination series, the remaining doses should be delayed if they've identified their pregnancy until after delivery. They should be reassured that available evidence does not indicate any increased risk of adverse pregnancy outcome after vaccination. There are a few studies on HPV vaccination. A few offsprings have been identified with congenital anomalies like ankylosing, congenital hydronephrosis, congenital megacolon, clubfoot, hip dysplasia, with the use of quadrivalent HPV vaccine within 30 days of estimated time of conception. But an expert panel deemed these to be unrelated to vaccine exposure. But studies are still going on and data are limited. They are emerging, but they are similarly reassuring as well. There is a pregnancy registry which has been established for the nonavalent vaccine as well as for the bivalent and quadrivalent vaccine. Now, advice about postpartum vaccination. The two vaccines that should be specifically administered at the time of discharge to protect the mother and neonate are MMR vaccine and varicella vaccine. For MMR, women who have not received it should be counseled to avoid becoming pregnant for 28 days after vaccination. Similarly, if women have found to be not immune to varicella, vaccination is to be given in the postpartum period. It is a live attenuated vaccine and given in two separate doses, 4 to 8 weeks apart. They should be advised to avoid pregnancy for at least 1 month after each dose and avoid contact with other susceptible pregnant women should post vaccination rash occur. So, finally, an ounce of prevention is worth a pound of cure, as rightly said by Benjamin Franklin. Meanwhile, in 2020, when the whole world is trying hard to combat the pandemic caused by COVID 19, and we are so eagerly waiting for the vaccine to be launched, it is a matter of speculation whether this vaccine would be used in pregnancy or not. This is a different type of vaccine in which the genetic material, the mRNA of the virus, is being injected, and that results in production of antibodies against it. Trials are still going on. If you have any questions, feel free to contact me or send a message. Do subscribe to my YouTube channel. There are many more presentations which would be useful to all of you. Thank you.